Diamond Orthotic Lab produces these bite sticks that are in segments, 2 millimeters starting and each 1 millimeter thereafter up to 10. We used to make 1 millimeter, but they were so flimsy that they didn't really hold up and they're not really practical. This has worked out to be much better. Now, the amount of vertical is matched to the person, but there's a range between the minimum, which is 66, and the maximum, which is the rest after 75. So you have to match the amount of vertical that you capture with how much posterior clearance there is. And so there's a minimum for every type of appliance. So Diamond Lab has produced these charts to tell you exactly how much vertical you need to make each appliance. So let's say you're going to make a daytime appliance for a person who has facial pain, and you're going to use a PMT base. Well, the chart here shows you that you're going to need 1 millimeter of posterior space here. So even if this is 3 millimeters anteriorly, you may still not have a millimeter back there. So that's why you've always got to check in the most distal area. If you're going to make it out of acrylic or anything else, then this distance has to be greater. So it's another 0.5 millimeter, so at 1.5. So you can see how these just match up. Now, for nighttime, if you're going to use a nighttime positioning technique or decompressor, regardless if you make it out of PMT or our new printed materials, type 12 nylon, that you're still going to need 1.5 millimeters of posterior clearance of clearance. See, in other words, you have this decompressor, so not only do you need an additional 1.5 for this portion, but you need a total distance of the posterior teeth at 3 millimeters. So you're going to need 3 millimeters in the back in order to produce this that will end up having 1.5 millimeters separation when you deliver. And now for the appliances for apnea. So the most minimal distances is the Panthera, and so this is the type 12 nylon that has the fixed components to it, very flexible, doesn't cover the anterior teeth, so you're going to get more movement with this. But this is the smallest amount of vertical, so you'll need 3 millimeters of posterior interocclusal space for this device. The EMA, because it has the PMT base and then has the pads in the posterior area, the advantage to this appliance is that A, it's very thin. However, the problems are that the attachment prefabricated acrylic attachments here have difficulty adhering, and the advantage of this device is the elastic component to it. The good part about this is that you can actually measure how much activity there is, muscle activity, and therefore address that either pain or nasal breathing or whatever the issues are that will require you to have a stiffer dimension. Problems is it comes up over the top here so the cheek can rub on that, the round design. And I've had, these have some latex in them, so I've had some patients with allergies that have had sensitivities. To make this device, you're going to need 4 millimeters of posterior interocclusal space. The Somnodent, you can see, is quite a bit more acrylic, and in order to produce this, so if you have a small oral cavity here that you're trying to make an appliance for, and you're trying to create this greater opening, but now it's taken up with the acrylic, just understand that you may have some problems with that. And these are more rigid, a little more difficult for the bruxers. That's why these little dorsal fins here can be a real issue for those kinds of patients. You're going to need 4.5 millimeters of interocclusal space to produce this type of appliance. And the type of appliance for sleep that requires the greatest amount of vertical is the Oasis. And so even if it's slimline version, it still requires 5.5 millimeters in interocclusal space. So you're going to have somebody with a pretty big mouth to be able to accommodate this device. Now, if you get into the newer devices, the DDSO, which now is the only device that allows for mandibular component of titration, but also has a vertical component of titration, along with managing the tongue with these removable tongue lifters here, and adjustable nasal if that is required. This device is made out of the same Type 12 nylon as the Panthera, but take a look at the finish difference between these, how rough this is, and certainly this was an improvement over the Narval, its predecessor, but we've taken this to another level. You can see the gloss finish on the printed appliances that we produce. So this is much more comfortable, and the dimensions allow for any type of distribution. So if you have a person with apnea and you're just with not a lot of bruxing and grinding, you can put the pads on the back, and you would need 2.75 millimeters of interocclusal space for that. If you decided that you have a clencher and they're clenching, they wake up with temporal headaches every morning, you want anterior disclusion, you can put the pad in the front. And if you do that, then you need an extra millimeter. So you need 3.75 millimeters of interocclusal space for that. Now, if you had a patient who is clenching, but you know they have apnea, or you suspect they do, then you could make a tripod where you have the anterior portion is 1 millimeter greater than the pads in the back. And if you knew that nasal surgery was something that they might consider later on, and perhaps they didn't need this anterior portion, then you could make this 1 millimeter greater than the posterior pads, and then that would have the anterior discluting effect, as well as keeping the mandible forward. And then later, if you didn't need that, and they didn't, after they have nasal surgery and not clenching anymore, you could remove the anterior portion, and now it's just resting on the posterior pads as someone who has nasal patency but has oropharyngeal collapse. So if you do that tripod, you need an extra millimeter, so that would be 4.75 millimeters of clearance in order to produce that type of appliance. But you can see how thin and how comfortable something like that might be. Okay, and now for your most difficult cases, where you've got a situation where perhaps somebody has a very small oral cavity, has a very large tongue, has very overweight, obese type patient, and whatever other health issues the person might have, but let's say they also have osteoarthritis, so you need to put something in their mouth to decompress their jaw to address their osteoarthritic condition, but at the same time, you want to make sure that they're optimally ventilated. Well, then you could produce a hybrid. Here, this is showing you the printed version of a hybrid that has a quick disconnect. And so you can either have the pad anteriorly, as I was speaking to, or you can place it posteriorly. One of the nice things about the new straps that we've developed is this material is Santoprene. So whether you get it in the more resilient blue or the more flexible orange, these are both Santoprene, so they're much more durable than the elastic EMA. Notice how they're trimmed out so they don't extend above the edge, so the lip doesn't get caught on them. And notice how flat these areas are, but you'll notice on an EMA how they bulge out and they rub on the cheeks. So these are all improvements that we sought to correct from patients complaining about different types of devices. And in this, the beauty of it is that, let's say they need optimal component. You just snap these parts together. They adjust to whatever levels that the patient needs. These slide in and out. These are adjustable right and left because sometimes people have one small nares and the other large. So you have to fit these, and then you just slide them up until you get a good seal, and make sure that once the patient has you've delivered this with the CPAP and you check it in your office, make sure you always lay these patients back when you check the delivery of these appliances. And in this one, have them bring their CPAP, hook them up, and then just see if there's any leakage around the nose, and you adjust accordingly until you have it sealed. And then, of course, if they have a CPAP, recommend they go back and have that titrated, because now that you're holding the oropharyngeal airway open, this should reduce the amount of pressure that's necessary to ventilate them. And very often we're seeing people that we have reduced them to the point of the lowest setting for most of these pressure positive pressure machines. About 4 is about the pressure, that is the minimum. And so there are some patients we've had where we have actually had better result with the oral appliance as opposed to the CPAP, or the CPAP and the oral appliance. So there's some cases that we have been able to just remove this and then trim off the tab, and now you've got the optimum treatment. Everybody's different, so you have to have all of your options open when you go into these cases where you're dealing with people with multiple problems and multiple obstructions. Well, thank you for watching. If you have any other further questions, please contact Diamond Laboratory in regards to appliance design, problems that you might be having. I think if you scan your models or scan your patients with the 3D scanners, dramatically improves fit and ease of delivery. And the steps to which we deliver are all covered in our courses. So we encourage you, if you have not been to a course to understand the applications for all the devices that we just shared with you, that you come out and visit us for our mini residency. It's a 3-session course. The first is on the diagnostics, basically how you come to evaluate a patient and how you would understand how to go about treating them for both craniofacial pain and sleep breathing disorders, whether they be adults or children. Session 2 is about more into the appliances, more about sleep, understanding sleep studies, getting all the basic information that you need to be able to follow up, because once you make these things, you have to go back and check and see how efficacious they are. In session 3, we talk about tough situations where you may have started a case but then have run into difficulty using other techniques, how to correct those, what to do about these finished cases where you have bite changes, whether it be a prosthodontic, orthodontic treatment plan. These are all covered in the session 3 course, and we hope to see you then.